Okay, so today I'm going to talk about the patellofemoral pain syndrome and my evidence-based protocol that I found that would benefit patients of this that have this pathology. Little introduction, I'm going to talk about the etiology, my SMART goals in accordance with the phase of rehab that they go with, and then the modalities that I would use within each phase of rehab. So a little bit of etiology. Patellofemoral pain syndrome is often described as anterior knee pain, and so anterior knee pain is a very generalized term, but it is very indicative of this patellofemoral pain syndrome. There are a lot of different causes of this patellofemoral pain syndrome. One would be overuse, malalignment of the patella causing grinding of the patellofemoral joint, chronic imbalances, like muscular imbalances, bad mechanics, neuromuscular problems, just all kinds of imbalances, issues that could be causing this irritation, and then trauma. So it also can be acute trauma, surgery causing the imbalances or the irritation around the patellofemoral joint, or a direct blow to the joint. Symptoms include stiffness after sitting for long periods of time, popping without true locking. So meniscal injuries, you have that true locking of the knee joint. With patellofemoral pain syndrome, it feels like it's going to lock, but you can actually go through the whole range of motion. Pain with squatting, kneeling, jumping, and going downstairs. So any kind of eccentric loading to the quadriceps muscle is going to irritate pain. And then kneeling is that compression on the patellofemoral joint that is kind of shoving that patella into the femoral groove that could cause pain. And then pain is often diffuse but gets worse throughout the day and with the more activity that is being done. So SMART goals for immobilization. These would all be within the 4 days of my initial evaluation. My main goals would be decrease pain with walking to 2 out of 10 using the global rate of change. Decrease swelling to equal contralateral side. This would be measured in by the girth measurements that would be taken. And then also reduce use of pain medication from whatever they're taking, usually something around 12 or 2,400 milligrams per day to less than 800 milligrams per day. Okay, so modalities for use. And then under each modality, I have an example of my parameters, possible parameters that could be used. So cryotherapy would be used to decrease pain. This would be done by reducing nerve conduction velocity, thus activating the A delta and C fibers, the painful fibers. And then this would increase the stimulus of A beta fibers, so the A beta fibers would block the painful fibers at the T cell according to the gate control theory. And then decreasing swelling by increasing fluid viscosity around the injury, and then also decreasing the amount of oxygen needed so decreasing cellular metabolism, decreasing the need for oxygen, and then decreasing the amount of blood flow that is needed to go to that area. This would decrease all of the swelling and the excess fluid around the joint, and then also decreasing secondary injury due to the decrease in oxygen needed in the cell. This would decrease enzymatic activity as well, and then this decrease in enzymatic activity would cause a decrease in overactivation of the phagocytes. So the cell wouldn't be getting too much of the inflammatory happenings. And then for laser, how laser works is still kind of undetermined in terms of physiological effects of it, but it is thought that pain relief is achieved by the absorption of light in the mitochondria, so that creates more ATP. This more ATP stimulates the electron transport chain and mitochondrial respiration chain, and this is thought to decrease pain and pain reception in the pain-producing tissues, So kind of like muscle spasms in the tissues, that is a pain-producing tissue. And then this decrease in muscle spasm would obviously decrease pain and increase tissue healing, because then the muscle is able to get out of that pain, spasm, pain cycle, and then tissue healing can occur. Electrotherapy would be put on a sensory setting, and so this would cause an analgesic effect by providing stimulation to the nervous system, which again would block the painful stimulus at the T cell, resulting in pain reduction. Modalities not for use would include thermotherapy, massage, and ultrasound. All of these modalities increase blood flow to the area, and that's not what we want to do in immobilization. We want to decrease blood flow because we want to decrease the effects of secondary injury and the inflammatory effects that are happening. And then also thermotherapy, it along with massage and ultrasound, it would increase swelling by increasing the tissue temperature, which then would increase the cellular metabolism, which increases the blood flow needing to come to the area because the cells need more oxygen that it's in the blood, and this excess blood would bring more fluid, and it would just cause an increase in fluid, thus causing an increase in swelling. And this is true for massage and ultrasound as well. Excuse me. So the next phase would be progressive resistive exercise. Again, my timeline would be all within 1 week of progressing out of immobilization. So there'd be I would try this. These are my goals. Increase strength to 4 out of 5 on MMT scale. Decrease pain with exercise to 2 out of 10, measured by the global rate of change. And increase range of motion to equal contralateral side using goniometry. So during this phase, I could use all of these modalities. It just depends on how you use them, is whether or not that they would be indicated or contraindicated. So thermotherapy, massage, they would be used more of a prior to modality to warm up the tissue, increase blood flow, excuse me, increase some tissue healing by bringing blood to the area, and also massage, effleurage and petrissage would be utilized, because then the effleurage helps bring that blood flow to the area. Petrissage is going to help separate the muscle and the fascia, and this is going to help increase motion at the in the muscle and on the fascia, and this is going to cause decrease in pain and increase in range of motion, because this movement is getting better from this. Ultrasound would be honestly its own treatment. This is because the decreasing pain, I would use this in case there were trigger points in the quadriceps. These trigger points caused from muscular imbalances, adhesions, causing pain, and there would be increased range of motion and decreased pain by the ultrasound treatment, because these releasing of trigger points would then decrease the patient's pain, thus increasing the patient's willingness to go to their full range of motion. Also, modalities for use, cryotherapy. This would be post-exercise therapy. So after the quad strengthening exercises that would be utilized during this phase of rehabilitation, any kind of post-exercise pain would be controlled first by cryotherapy, is what we would plan on using as our post modality. We could also use laser or e-stim, but it's also important in this phase and the next phase as well to realize that we are most likely going to be treating the pain as a result from the exercises that we are doing during this phase, not necessarily the pain that is as a result of the actual injury. So cryotherapy would be used to decrease pain by, again, initiating the gate control theory. Laser, again, it's not as researched on as cryotherapy because it's relatively new. And this pain reduction could again be caused by the ATP production and then the stimulus of the mitochondria, or it could be from endorphin production and opiate receptor binding on the cells producing pain. So this in turn would shut down those cells and shut down the pain being perceived by the patient. Then E-stim, here is another sensory setting, and this would cause, again, the analgesic effects from stimulating the nervous system, and this would cause, again, the gate control theory to kick in and decrease pain. All right, so goals for functional phase of rehab. I would increase proprioception to full capability, and I would measure this by the ability for the patient to stand on the balance board for 1 minute with 5 errors, only 5 or less. I would increase strength on affected quad to contralateral side with a 5 out of 5 MMT scale, and increase patient confidence to full confidence using the fear avoidance belief questionnaire. Again, this phase of rehab, it's a lot like the last phase. We're going to be initiating some more functional rehab exercises. Again, and these modalities are going to be the same as the previous phase. They're going to be treating the pre and post exercise pain, mostly the post exercise pain, because at this point we are doing these activities and we are refining these activities that are stimulating all of the muscle fibers and neuromuscular fibers and all of that. And so we're not necessarily treating the pathology with these modalities at this point, more of the effects from the quad strengthening exercises and proprioception exercises that would be implemented during this functional phase of rehab. So all of these would be the exact same as the previous slides. Ultrasound, my main thing with ultrasound, I wouldn't use this unless all of the other modalities did not work. So ultrasound would be my last resort, and then I have a couple parameters down here. And the first parameter would be if there's pain around the patella tendon, and then the second phase or set of parameters would be more for the quadriceps, to getting that more deep stimulation of those muscles. Okay, so SMART goals for maintenance would include this. Obviously, we're in maintenance all of the time if we have progressed out of the functional phase. So this would really just be maintaining functionality with no pain. Again, going back to the global rate of change for that. Maintaining full range of motion and strength, again compared with contralateral side and MMT scale. And then maintain full confidence, again with the fear avoidance belief questionnaire. Modalities for use during this phase would basically just be dependent on patient pain. I would mostly use thermotherapy and cryotherapy just because they're more accessible than the other modalities that we talked about, besides massage. I would also use that. Massage and thermotherapy would be used more of a pre-activity modality to be used, and then cryotherapy would be a post-activity therapy or modality to use. Again, I would continue to check on the athlete for the confidence rating and the pain ratings as well. Conclusion: patellofemoral pain syndrome is often caused by chronic imbalances, overuse, and direct trauma. Treatment would mainly be modalities to decrease the pain from the different causes that could be causing it, either muscular imbalances, neuromuscular problems, anything like that. Increasing musculoskeletal strength and increasing neuromuscular control are the big goals of treating patellofemoral pain syndrome. And those are my references. Thank you very much.